transportation, housing, food, it's all very basic. It becomes so technical that sometimes we forget about the patients that are out there and don't have the basic needs. And then they, can't manage day to day. Cognitive deficits, and that's where we feel it's huge. That's where we get involved with a lot of patients. They have poor coping skills. Maybe their memory isn't so good, so things aren't going as well. So we have all this we've talked as a group in our department that, what is it that, when you get a referral, what is it that really you sense from that patient and family? And what we felt was the two criteria that really stick out are the cognitive deficits and the lack of support system. Really, impacted a bit patients' ability to manage their health care. So, or they may have a support system that's overwhelmed. The patient's been in and out, and that wife or daughter, or, son or neighbor or whoever, just they can't do it anymore. And a lot of patients that we have, that health care, the relative is a healthcare worker, but they're just like, I can't do it anymore. I can't be there for all those appointments. I can't. And so that's what we'll say. Well, you can, we'll be involved, and you can be the wife, you can be the daughter again. You don't have to be that healthcare worker. And then also, if they're missing a lot of clinic appointments, sometimes the doctors may label them as non-compliant. Patients non-compliant because they're not coming to their appointments. And we get referrals for that reason. They're missing all those appointments. So I got a referral on a lady, she was in her 80s, and she was missing her appointments in internal medicine and pulmonary and cardiac. And so they called, and I called her, and she said, well, the reason I haven't been able to keep my appointments is my husband has Alzheimer's. And he was to the point where he was getting bad. And so she didn't feel comfortable leaving him with a neighbor or a church friend or somebody. So she was canceling all of her appointments and not saying anything to anybody when she called in for the reason. So I got the social worker involved to help take care of the husband, so we could get him to an appropriate place so that she could, not only for her medical issues, but just, she was staying up. She was up 24 hours a day, and she had heart, and she's diabetic, and just all kinds of problems. So we got her back on track. And what I did was, until we got him taken care of, I said, I will call you once a week, and we'll check on your blood sugar, your weight, how you're doing, and then I will send that information to all your doctors, and then we'll stay on target with how you're doing. So then I sent a message via our electronic health record to all of our doctors and said, this is why she isn't coming in. She would love to be here for her appointments, but her husband's sick, and I'm going to call her once a week, and I'll keep you updated. So we probably did that for about a month until we got things in place for the husband, and then we were able to pull her back in for her appointments. And she did end up having she was missing a colonoscopy, so she did end up having a polyp too, that had been canceled for 3 or 4 times. And so she was a young lady, and so finally we were able to get her in and help her take care of her problem. And as far as making referrals, anybody can make a referral. It doesn't require a doctor's order or anything. Nurses, social workers, the NA does the medical systems that we use a lot in the clinic at Henderson. A lot of times they may be grooming the patient. The patient may share a lot of information with them, saying, things aren't going well, and I've got all these problems. And so a lot we've gotten some referrals from the medical system. We'll go to the doctors and say, what about getting a care coordinator involved? And the doctors usually are very agreeable to have us involved because it is the patient is maybe being seen at many different places, and we can help them stay on top of all that information. We could even have patients calling us saying, my so-and-so has a care coordinator. I'd like one now too. So we're like, so the word is getting out there. We got a referral from a gentleman called, and his dad was in the hospital. My dad's been in the hospital for 7 weeks, and I just he was having so many problems, and he said, he was from out of town, his son, and he couldn't be there a lot. He said, I just feel like my mom doesn't have one point of contact. The patient was transferred from ICU to the neuro floor, back to ICU, back up to the floor, different wing, different nurses, different social workers. The neurosurgeons stay the same, but then a lot of times the other services, those doctors changed, and he didn't feel like she had one point of contact. So I got involved, and it was great, we followed him during his hospital stay, and he did end up, he went to rehab. Went to the rehab course, and I followed on the rehab course. He did end up going home and he called me the other day. He had a neurosurgery, day surgery, went home, got infected in MRSA, and the neurosurgeon said that was the worst case he had seen in his whole career. I mean, this guy was confused, agitated, everything. And so, I got involved and kind of looked at the whole story, and we eventually got into rehab, but then, he got home and he called me the other day and clear as a bell now. And he got his driver's license. He called me and said, I passed my driver's license. So it's being able to follow up with those patients that's the great thing about this job. When you're in the hospital, you send them home, you wonder what happens to them, and we're in the clinic. And so we do follow them and keep in touch with them through whatever they're going through. Sometimes there's someone outside of the family who calls with a referral that's always kind of touchy, they think that things aren't going well. So we have to talk to the patient and the family and say, we got this referral. Sometimes the person wants to remain anonymous, but we call them and then we have to work with their providers. And, we don't need a doctor's order, but we work so closely with the doctor and the whole team, our nurse practitioner, or physician assistants, that we say, we always notify them, we got this referral for care coordination, and, we're going to be part of the team, and what type of issues you feel maybe have been going on that you would like us to follow up on. So like I said, they're very receptive. And then when we get the referrals, and how do we evaluate them? Like I said, we review their history of the use of the healthcare system. Are they missing appointments? Are they, maybe they were with diabetics, they were coming in for their diabetic education, and now it's been 3 years, since they've been into diabetic education. Why is that? Or if they've been in and out of the hospital, and what's going on? We use a consistent questionnaire because with 24 people, we want to make sure we're all screening them kind of the same way, asking the same questions. So the things that we really look at are they managing their medications okay? Do they know what their meds are? Do they know what they're for? Can they get a refill? Again, it's very basic things, but it impacts their ability to manage their disease processes across the continuum. Appointments, are they keeping their appointments? Do they have transportation to get to their appointments? Just simple things. Community and social services, and the big thing is the plan of care. Do they, we ask patients, do you understand what the doctor's plan of care is for you? Are you able to follow through with it? If they're asking you to monitor your weight, do you have a scale? It's as simple as that. Well, send the heart failure patients home to check their weight every morning. If the diabetics check their sugars, do they have a scale at home? Do they have a thermometer to check their, if they're surgical patients, to check their temperature when they get home? So it's just some of those basic things. And, when they can't follow through with it, again, it's always a question why. Why can't they follow through with it? Is it maybe has their mental capacity changed? They're just so overwhelmed, they have to kind of gear it down to, okay, let's just deal with your blood sugar this week. Next week or a week down, we'll deal with your weight. We just want to get you to start doing one thing at a time. Again, it's that cognitive, their own cognitive or their support system's cognitive ability. And again, it's the compliant, adherence. I don't like non-compliant. Are they adherent or non-adherent to? And again, why? Why can't they be adherent? And the patient does have to agree to our involvement. Sometimes the doctor calls with referral and say, I really think it would be great to be involved. Call the patient, and the patient's like, the patient wants it, but then the wife may get on the phone and goes, I'm managing it, I'm doing okay, but the doctor says to us that the wife's overwhelmed and she's not keeping track of things well, and so we're kind of like, we can't force ourselves, force them to accept our involvement. So a lot of times we'll give them our name and phone number, or we'll say, when are you coming in for an appointment? We'll just meet, face to face. A lot of times when you meet them face to face and they can see who you are, then they're more accepting. Or again, they may still decline, and then if a crisis happens, then we usually get a phone call. I think you could help me out now. So that's fine. We get involved when the patients are in the hospital. So we do inpatient, outpatient, we call them, we keep track of the patient wherever they're at. We really are involved in that interdisciplinary plan of care. We're part of that team. It's a great benefit because, like I said, patients may transfer from unit to unit. And who is that consistent? And the doctors may change, especially if they're here for a long time, that service, that hospital service, because we are a teaching institution. So the doctors usually are on for a week with their team of residents, and then they're off, and then there's a different team the next week. And so for them to know that patient story of what happened in the previous week It's in the chart, but it's just, you know, condense that down. Again, we share the patient's story. If we're already involved with them, we get up to the floor, we, you know, tell them what's been going on. We really try and get them up to speed. It saves them a lot of time of having to read back through the notes. We work with the bedside nurse, we work with the social workers. We document the progress notes in the hospital. We communicate with the patient's interdisciplinary team. We help organize care conferences. You know, trying to get all those players at the table together. And that even happens in the outpatient world. I had a patient who she was bilateral amp. I got to know her when she just had one amputation, and then she ended up having another. She's dialysis, she's diabetic, but she has, she's so positive. And what she lived for was her son, who had, she was 62, she wasn't much older than that. And her son was in his 40s, so he had heart problems and was kind of waiting for a heart transplant. And then she was diagnosed with breast cancer. So it's like one more thing. So they have a breast cancer review every week. They review the new breast cancer cases. So I went to that. They asked if I would come, since I knew her so well prior to the diagnosis of breast cancer. And so she had had cancer before, and the radiologist who was involved at that time was there, and the surgeon was going to do the breast cancer. And I think she had already had the surgery, so you know what the treatment was going to be. Well, surgery. So we talked about her case, and the radiologist said, well, she doesn't have 2 legs, and she's dialysis, so she might as well just not do anything. And I just looked at him and I said, but she wants to live. She wants to live for her son. We can't just write her off, because she's got a lot of medical problems, and she was 62. If you look at her, you go, oh, why do you want to live? But she wanted to live, and so that's where we truly advocate for the patient and know that story, and that we're involved wherever that patient's story is being talked about. If it's at, case conferences, or when the patient, especially when the patient's not there, to be able to speak up for them. So she was, then I did follow through with treatment, and she was very complex because she lived like an hour and a half away from La Crosse, and in order to do her treatment for her breast cancer, they didn't do it in her local town, so it had to be in La Crosse, and she was a dialysis patient. So I worked with the county was involved with her, and the doctor said the only way that I'll do her treatment is if she stays in the nursing home during the week up here in La Crosse, and then goes home on weekends. So I worked with the county to get them, to say this is what the doctor's saying needs to happen. Are you willing to help fund the nursing home stay during the week, and then she can go home on the weekends? And so getting all the players together on the same page. A lot of times we're making phone calls to many different people to relay that doctor's plan of care and how can we orchestrate this. So it's no day is ever the same. So we do have consistent contact with the patient on the phone and through the clinic appointments in the hospital. And if the patient goes to a nursing home, a lot of times it's a short-term nursing home stay. We'll be involved while they're at the nursing home also, as far as relaying the patient's wishes and the previous plan of care. And then when there's care conferences, to know what we arrange for when they leave there, or to say, they're not ready, the family's not ready to take them. A lot of times maybe not wanting to speak up, and then we'll speak up to the family and say, not yet, we need to come up with a different plan. A day in the life of the care coordinator is never the same. We may start our day thinking, okay, we can always look ahead and see who's going to get to the clinic, but then we never know who's going to land in the hospital. So we may pull up our schedule, and we may have 3 or 4 clinic appointments that we need to check, follow up on, or meet the patient at, and we may have some patients in the hospital. So we're like, okay, we can do some phone calls, and we can get this all done. Well, I had my day, and I thought I was going along. Well, I got a phone call from the social worker in the hospital, and she said, this isn't about your patient, it's about the husband or relative of one of your patients. And okay, so he was in the hospital, and he was worried about his wife at home because he had she was diabetic and in a wheelchair, and needed her legs wrapped, and insulin and pills, and he did all the cooking. So, then I dropped whatever I was planning on doing, and called her and said, we kind of talked about what she felt that she could do, without him being there. If she felt safe getting around, place. So this was, 3 o'clock in the afternoon, and she said, I haven't had my leg wrapped since yesterday noon when he went into the hospital. So I thought, okay, nobody, so I went out and did a home visit and wrapped her legs and got that going, and then I called the social worker that day and said, she felt that since the husband had done all the cooking, can we get Meals on Wheels? So the social worker and get home health set up to continue to do it. I said, I can go out a couple of times. We do home visits, but it's an exception, to try and sometimes get that care started and then get some home care in there to continue to do it. So the social worker was able to get, home care to start like on Friday, so I did, the visit the next day too, and then we got Meals on Wheels, and then the husband, so we really tried to help orchestrate her care because he was not there to help her. And then we do use a care coordinator department. We have to have students come and shadow us for a day. There's one of the, in La Crosse, there's a university, and then there's a technical school, and then up the river in Winona, Minnesota, there's also another university with a nursing program, and then we also have some students from Madison that do their clinical at Gunderson. So there's quite a few nursing students that do their clinicals at Gunderson. So a lot of times they may spend a day with us just to see what it's about, and a lot of times it's senior nursing students who are doing their leadership curriculum. And a lot, then also I think one of the technical school, I think, because when they do a psychiatric rotation, there's so many students, and maybe there's not enough patients in the psychiatric department, that they may shadow the behavioral health care coordinators for a day or two or whatever needs to happen, because it's a good fit to see what happens on that once that patient leaves the hospital doors, be it emergency room or hospital, as far as what they have to deal with. So a lot of the students will say, this is what I want to do down the road. And because we do really require that the nurse have at least 5 years of experience before they come to this role, because it is an independent role where you're you're working with the doctors and sometimes at the appointments and in the hospital, but a lot of times when you're talking to them on the phone, you're doing a lot of telephone triage and trying to decide, do I need to be contacting the doctor, or can I give them, some direction, and then call them back the next day. And so you need to be, pretty independent and confident in your assessment skills. So it's, like I said, we do require to have 5 years of experience before they come into this role. And my daughter, who was at the local university, did rotation with the pediatric care coordinator, so she'll share her thoughts about how she thought that really helped her prior to going out into the real world.
Hello, my name is Jenny Tucker, and I actually was in your seat about 2.5 years ago. I did what actually ended up happening, how I stumbled upon this, is they were cutting our clinical class for our senior practicum, which I'm sure some of you may be able to relate to or will be coming up towards shortly. And so my mom suggested this and thought it would be a great fit because I wanted to go to the NICU so I could work with the peds care coordinator. I ended up with my own caseload of patients. I was there for about 5.5 to 6 weeks. I had my own patients that I followed while I was there, plus I worked with her on some other issues. And it really helped me feel comfortable being independent and also working with maybe community resources or even just, working with other providers and making those phone calls and being the one to call and say, hey, can we do this? One of my patients I had was a little girl who had osteopenia imperfecta, was getting infusions at home at night. She had a Hickman. They had to keep, changing, dressing, changing needles, getting her to come in for appointments on time, making sure her dad understood the importance. They were months, there were some things that we had to worry about. And then, it was like a week and a half before I was done, her mom was a month. And so then it was like finding resources to figure out, okay, now, this mom's not there, who's going to help with things at night, at home? Who's going to make sure she gets to her appointments? And kind of realizing that you need to really look at the whole picture. And it's really helped, now that I'm in the NICU. I've been in the NICU for about 2.5 years, and it's helped me get a better perspective when I'm looking at my patients, especially when we get close to discharge, and it's patients we've had for 5.5 months. These patients don't have a history, they don't have a primary care provider to go back to. We are their history. And so it's nice having had that experience in nursing school. Even though I couldn't start a job like that right away, having that experience has made me feel a lot more comfortable in getting ready to discharge my patients and making sure that we have all those aspects covered, their basic needs, financial, making sure all those things are covered, and even, making sure we get our social worker involved at work. So it's a very nice way to have that leadership opportunity, and and just kind of starting to learn those roles while you're starting nursing school and have kind of that guidance, so.
Any questions anybody have?
Go ahead, yeah. Well, I trust you. It sounds like a wonderful position to have in the hospital, and it really addresses a lot of the issues that I've been dealing with as a nurse, because there are so many other, like, psychosocial issues that you're facing and the financial issues, and it's so overwhelming sometimes as a student nurse to interact with patients who have so many things going on that you really feel like you can't do anything about. And so I'm just really impressed with your role and what your hospital is doing and the initiatives you guys have. And I guess I have sort of a few questions. So I guess you kind of answered a little bit of it about how to enter this position and using that there's a requirement of experience, which I understand. So I was wondering, do you guys have papers or research that you've done and published articles that we can read about, like, I guess how to start or how these programs start or how your hospital is started?
We're hoping in April, we did a joint article with one of the physicians in the institution, so there's an article that's looking at, really the institutions want to know the dollar figures and return on investment, and so we've kept all those statistics, and then we've done the financial piece of this role. So there is an article being written, and hopefully it'll be published this month. I tried to get a hold of the doctor to see if it had finally gone through, and she said she hadn't heard back yet. So it's going to be in more of a family practice type journal. And we also are going to write it up in a certain nursing journal too. And I think in the previous session, somebody had asked about like the homeless patients, and we don't, when we get a referral, we want to know what their insurance is, because we want to know do they have insurance or not, because if they don't, even if they do have insurance, and they're struggling with the type of coverage they have, we get the social workers involved. If we hear no insurance, a lot of times we'll say, was it a loss of a job or what happened, so the social workers are immediately on that case. We don't say, if somebody had said, is there a quota of, somebody non-insurance? No. We just, whatever the patient needs, it's more their medical, needs, and then the insurance, we make sure that they have some coverage, or that we can get them into a program that will get them coverage. And if we can't, then we negotiate with the doctors as far as, coming in for appointments and medications and things, so.
So actually, I'm sorry, it just reminded me of another question I had. So I have two more questions. I was thinking about funding for your position. You said that it was a pilot project and that it started as a sort of testing, and then you guys actually become a
department.
Yeah,
right? It was a pilot, and then we did become a department, and the organization feels that the return on investment that what we've saved, and because with the ERGs, they only get paid so much for a hospital stay, and so if we've been able to shorten that length of stay, help work on issues as they go along versus letting, maybe getting the therapy in there sooner, or, evaluating for home oxygen sooner. Really sometimes it just kind of, when they're in the hospital, there's so many issues that they don't think about discharge until they've been there 3 weeks or 4 weeks. So they found that with our involvement, we've been able to hopefully, save some dollars that way, that it's worth the return on investment, plus the satisfaction for the patients, and they're not using the emergency room inappropriately, they're not using the urgent care inappropriately, and it's open for other patients who do need it. And it's really what we've seen is that we've decreased their hospital and emergency room and urgent care, but we've increased the clinic visits, because we get them in for their, maintenance visits, we get them in to see the providers that they need to be seen versus not showing up at all and then ended up in the emergency room, so.
And then sorry, the last question is, do you know of any other care coordination type roles in other hospitals in other states?
There's not a lot out there. We did a literature search, and there's, chronic care models, there's Kaiser, there's, Quaker, there's a lot of, but a lot of them are either community-based or facility-based, and they don't really follow the patient across the continuum. So when you have to transfer information from, care manager out in the community to a care manager in a facility, there's always the chance of information not transferring appropriately, whereas we kind of follow the whole story and know we follow them wherever they're at. So it's new, and they're trying to promote it, and I know that the healthcare reform, I think we talked at the beginning, was talking about care coordination as being one of the up-and-coming things, and in and out there, and so we're kind of evolving very quickly, so, yeah.
I also think it's a wonderful idea. I'm just a first semester professor. One of my patients during my clinical rotation had been in the emergency room 5 times this year. And I'm like, something's not working here. So I think it's a great thing. And I just wanted to ask generally, I don't know if you could tell me for either non-disclosure or whatever, but what is the return on the investment? I mean, if I wanted to fix this at somewhere,
There is dollars saved,
yeah.
as far as, yeah, thousands of dollars saved.
Well, maybe can you tell me how you went about calculating that in terms of with the what's that?
We had a biostatistician. So what we did was we looked at our patients a year prior to our involvement, what was their activity, emergency room, clinic, cancel appointments, whatever. Because when they cancel appointments, that's $200 lost, because then that time isn't filled with a patient that should have been there. And then we look at a year post our involvement. So we really give it time, because once, you get to know a patient and they said, really, it takes time for them to really trust you, and, sometimes initially they may not be calling me, they may be calling their doctors. It's like, you need to call me because I'm that one point of contact for that patient. If they have a lot of doctors, they can call me and I can, get the information from all the different providers. So, it's, it's evolving. It's a good program. We're not, our director has said, we're not going to add positions even though we may be busier. We just need to think, think smart and think efficient, and, do we need to be at every appointment, and can we, somehow communicate our involvement to the doctor, and then he can call us back. So it's really looking at our involvement and keeping in touch with the patients by phone a lot in between.
So one other quick question. I think your workload loads are 50 or 60 patients. How is that working? That seems like a lot.
And they're not all. You may have 20 or 30 of them that are really, the fighters are burning for those patients, and the other ones are doing okay. And as you, get things set up for that patient, appointments, transportation, maybe making sure somebody's coming in to check on them, you kind of back, if they're keeping their appointments on their own, they go to the appointments and understand the information, you kind of slowly back off to see how they do, and if they do okay, then you kind of, talk to them and inactivate them. And then, you say, but call me, if something happens where you're not doing as well, and then I can get involved again. So, it's been, it's fun. It's no day's ever the same. It wasn't a job. It's, like I said, all my different experiences that I had in my past really have helped to shape, and that's most of the nurses that I work with have been in different departments, and, all of us together can figure it out for some of these patients that are very challenging. Any other questions?
So, I have the same question, 50 patients. So, any given day, you're assigned 50 or 60 patients, but on any day, you don't necessarily have to work with that many.
No.
That's just how
That's
many
your caseload. You may talk to them once a week, once every couple weeks, when they're coming in for appointments, they're in the hospital, and sometimes when you have 3 or 4 patients in the hospital, that gets to be very busy because you're running to different floors, and trying to touch base with all the doctors and come up with plans and organize, helping organize their care, because we know how busy it is in the hospital. And, I had a gentleman that was in, he was on a vent, and he had therapy, and he had dialysis, and we were trying to wean the vent, and then trying to get him out of his room, and, the nurses were just, struggling, and I would go to the nurse and I'd say, what can I do to help you manage this patient better, because I have the time to call those different departments and say, let's come up with a schedule, let's keep therapy at this time, and then dialysis is going to be at this time, and so the patient can get what he all needs in order to get out of the hospital. And so it's really, working together. Yeah, it's not, we don't have them all. No, it's just, and some of them, if you haven't talked to them in a while and they're doing good, you call them, they're doing great, and that's always the thing. If you haven't heard from them, are they doing okay? You wonder sometimes. So you call them and they'll say, well, this is going on. But you gotta call me. That's what we're really trying to instill in them, is recognizing the symptoms that they need to be calling in about for their heart failure or diabetes, and to stay on top of it. So really working with them to recognize their disease process and how they can manage that best. So, nowadays I really think. Did you have a question, Sue? Okay. Did you have a question?
The articles will be coming out shortly, so if their email's in the handout, you guys can just get in contact with her with the email. She can send you the link and the reference for the article. I've read it, it's a really good article. Isn't it, it's healthcare, it's in economics, more of a Cohen's journal.
Because as the organization, they wanted to present, more of an organization in the journals that administrators and whatever would be looking at. So it kind of has two focuses, the nursing journals and then more the business administration type journals. So,
kind of a interesting phenomenon, I guess. It's sort of like your regular basis. Good, you got good competitors.
well, but it's going to be out. I mean, that's the healthcare reform is going to be they want care coordination for, and then how do you just get it up and running? When we were developing this role, we did literature, we did evidence-based, we did literature search on case management, care management, what types of patients do these people follow. But the only thing that's different from ours is there's a book called Status 1, and we kind of incorporated some of those thoughts into our program as it's gone along. But the gold standard, a lot of insurance companies do case management and care management, but it's over the phone. It's not face-to-face, and that's the gold standard, is face-to-face for these very complex patients, because they can be telling you anything over the phone, But once you see them and maybe see that they're not walking so well, that they're, they look pale, and, then and they're more honest with you when it's face-to-face. So really that's for those very complex patients we need to, like I said, we develop the criteria based on those doing the literature search, and then also on just our experience in knowing these are the patients that you need to keep track of to help them manage better. So good luck wherever you land.
I just had one more comment, I guess. As you were a floor nurse before, and I
did float, and I float nurse, and then I worked in a small hospital, and I've done coronary care, and I did home care.
Well, and I was just wondering, in your opinion, it just seems like to me to be a whole lot more emotional stress of the care coordinator, because you follow patients for so long, and you actually, I would think, follow them all the way to the end of life. Basically. I mean, is there like a support group for y'all as well?
Support group.
Like,
They are each other's
Right, and we do, like, when I did this the first year, and we do deal a lot with end of life. When these patients they've had enough, they just say, the doctors want to bring them back in, or they come into the hospital, and there's nothing, I've had some cardiac patients where there's really nothing that they can do for those patients anymore. So this one gentleman I had, he just said, I don't want to keep coming back. So I talked to the doctors, and he went to a nursing home, because he had been living with his mom, he was like in the 60s, and she was in her 80s. And but the nursing home sent him back the next day. And I said, no, he doesn't want, he had chest pain, so they're like, get him into the hospital. So I really worked with the nursing home and the doctors and I said to the doctors, where can we go with his meds? How much room do we have to, he was on cardiac meds, but I knew it wasn't at the top of where he could be. So we did a lot of med adjustment over the phone, and, got him oxygen, got him sublingual morphine, whatever. Then he ended up on hospice, and he did end up dying in the nursing home. But one of the nurses, when she first started, about 6 months into her role, said, we have a normal patient. And I said, those aren't our patients. We have the worst of the worst, patients. And I know one of the orthopedic doctors, because we follow those patients to whatever appointments they have, orthopedics, endocrine, podiatry, wherever they're being seen in the clinic, we, go see them. And the one orthopedic doctor said, they don't pay you enough to deal with the patients you have to deal with, So, but we support each other, and we just say, and we talked about this at our last staff meeting, is that we make sure that you're not taking it home with you. Because one of the nurses, she has patients calling her home, and I said, you can't do that. You're going to be drained before you know it. And, some of the nurses don't want to take a day off because they think, I have to be there for that patient. And I just said, no, you set up, you're part of the team, and you need to make sure that there's the rest of the team around you to help manage this patient, and if you're not there, they know who to get a hold of. They know you So, in the home, I think I learned that in home care, when I did home care for 11 years, is that you can't be that only person for that patient. That it's part of a team, and that you put the team together to help manage that patient. So, it's, yeah, like you said, you need to take time for yourself, and sometimes some patients, some nurses, if they've had a lot of deaths, the first year I was in it, I had 12 patients die, so it was almost one a month, because it was, I think initially when I started, a lot of the referrals that I got were more end of life, for the staff to get used to calling referrals and who would be appropriate for me to follow. So a lot of them I, helped transition into hospice and palliative care, and so it was, those kinds of patients initially, but now we're getting more patients that the staff is getting more used to our role and what we can do and how we can intervene, so they're calling us earlier in that patient's disease process. So.
I just have a question for your daughter. I'm doing research project on parent advocacy for the ill children, and I was just wondering, do you meet resistance in the NICU with this program, or do you find that parents are really receptive to it?
Well, I actually work at a different hospital now. I pray. I wish upon wishes that we had this type of program in my hospital, but it wouldn't work as much because I live in Twin Cities and we have, multiple medical systems. But I think, in speaking from having, worked with the pediatric care coordinator, they have somebody in the NICU at the hospital who, because they're there for so long, really helps, and is really an expert in those patients. And she works to transition them. The parents have already had somebody when they're inpatient, and so I think that's a nice pairing to then transition them to when they're out. And a lot of the NICU patients, especially the ones, in the first 2 years are your biggest 2 years, and so a lot of times they might, follow maybe the first year or two, and then after that, a lot of the other resources that are available are going to be the ones that are going to best suit their needs. As far as like birth to 3 and early childhood education, a lot of this can follow them a lot better. But I think because, and in most NICUs there are discharge coordinators or primary nurses, like we have primary nurses in our unit, so parents are used to having one kind of focused person. So I think the resistance is less than say maybe an adult who thinks an adult that should take care of herself. So
We really encourage the NICU staff to refer early on versus, when the patient's ready to, with the baby and parents are ready to leave, because they're so overwhelmed at that last few days to meet, a care coordinator who can continue to manage that patient's care, to really get them involved early on and meet the family and be involved in those care conferences. Even though we have a discharge nurse in our NICU at Henderson, there's, we have to have a smoother, like a handoff. And even for the adult population, it's like, we get referrals. We're going home at 2 o'clock today. Can you come and see them? We're like, we're in the middle of something else. We really like to see them before they leave and kind of get to know what the issues are. Sometimes we can go up there and meet them, and sometimes we can't. We review the discharge summary and, then call them at home, and we kind of fly by the seat of our pants a lot with getting up and going, on new patients. We, like I said, no day is ever the same. A lot of times we have to drop what we're doing with the current patient and go meet a new patient, and, maybe even for 5 or 10 minutes and just kind of say, I need a contact, because they like to put a face to a name. If they're leaving the hospital, you're going to be calling them, then they know who that person is going to be. So, did that answer your question? Yeah. The departments in the hospital and clinic and providers, when I first started this, it wasn't, I didn't have anybody to orient you. It's kind of like I was just starting this, we have a criteria, and like I said, I hadn't worked really in the outpatient setting. I'd worked in the hospital and home care, and the clinic setting is a whole other world. I really, learned. So it's like, okay, I'm going to pick up this patient. How am I going to let the doctors know and the nurses know that, I'm going to be involved? And so this is a whole learning curve across we've developed the role as we've gone. And like I said, the doctors, love us, and when they see us sitting in a room with a new patient, then they just go, oh, they've got a care coordinator. It's not going to be good. It's good in the fact that we're there, but they know that the patient probably has a lot of other needs outside of their department. So it's, the physicians and the providers, nurse practitioners, physician assistants are great to work with on these patients. So And a lot of times we'll call the nurses and say, I'm not gonna go in the room until you come, so you're there with me for the patient. And, because a lot of times they know that if they tell the patient information, they may not hear it correctly, and if we're there to actually hear it and can reiterate it to the patient, and, and even myself, when you go for an appointment and you get out and you're going, what did they say? What am I supposed to do? And a lot of times we'll take notes and then hand it. There's one patient I had, he had 5 appointments in one day. And you know that there's no, because he came from such a distance that he has closed open heart and he had a pacemaker and, there's all kinds of issues, new diabetic, and so he was making the rounds. That's what he wanted to do. So we, took notes at each appointment and said, okay, this doctor wanted you to change this doctor wanted you to change that, and then provided that to him and his family so that it was summarized as far as what the changes. So it's good, like I said, with the chronic care, chronic disease patients, that's just going to continue to increase until we can get prevention better under, more implemented. So I know I'll have a job until I'm retired, so, that I'll be employed with these types of patients, so. But good luck in whatever you do, so just be willing, if there's something new out there, be willing to try it. And when I started home care, I was the first, nurse to, we kind of started it with myself and another nurse, and then we ended up having about 20 nurses, and so I've always kind of been willing to step out and try something new, so.
What year did you year?
2003. We started in July of 2003. We started with myself in La Crosse and then a regional care coordinator. And then we kept on adding staff as we went along, like the specialty, the pediatrics, the behavioral health, more adults, and some of the regions identified that they felt that they needed a care coordinator. There's a couple areas that we still feel that are needed, but with the budget, we're not going to be adding positions at this time, so. Any other thoughts or questions? Feel free to email me or contact me if you do have questions as you go along. And one of the other things that was here earlier, she said that she's read about care coordination in some of her journals and books and whatever, so there's some information out there, but like I said, we are very unique because we are an integrated system, and I can practice, process. We do deal with patients that, let's say they have their primary provider outside of Gunderson. They're at a non-Gunderson facility, but they have all their specialty docs at Gunderson. So we do a lot of communicating. They love it too because we can communicate. We have the patient sign a release of information form, and we can keep that non-Gunderson provider updated with what we are doing at our facility. A lot of times the docs will, they dictate their notes, or the nurse practitioners or whatever will dictate that a copy goes to that provider. But a lot of, like with the medications and, how the delay in getting that copy of that to that primary provider may be low. So then we call that doctor right away and say, these are the changes that are faxing, faxing a copy of what was changed so that they can keep their charts updated too. So we communicate sort of within our own system, but then also outside of our system for the patients. Deal with a lot of transplant coordinators and, people out, because La Crosse is kind of halfway between Madison and Minneapolis, and then Rochester is a little, about an hour down the interstate, so.
I guess another question. So is the care coordinator program, is that a separate entity from the hospital? So I guess another question would be, how do these patients is it just patients who are admitted to this hospital who are allowed to utilize this team, or?
It's actually because this medical center started, there was a clinic and a hospital, and now they're together, and so it's all the facilities from the 21 regional clinics are all done as Lutheran. So it's all under the same name, and they all the same system, so it's between, everything's connected now.
So we get referrals, they don't have to be in the hospital, they can be, we get, patients in the clinic that are being seen, and the doctors know there's a lot of problems, so they'll call us for results, but as long as they have some contact, maybe it might be one provider that can understand, but the rest of them are, and that's where it really gets confusing, because the rest of their providers are outside of the system, and we have maybe one within the system, then the information doesn't get shared, and the patient is confused, and so then we try and get it connected. And like I said, any age, I remember a girl that I had that, she had T1, I think, and she had short bowel things, so she had a TPN, that's the infusion nutrition, at nighttime, and her port kept on getting infected. And then she was getting, working with intervention, where she would get the ports in place, and she was getting frustrated. So then they labeled her as non-cooperative, because she was just so frustrated with this port having to be replaced, and she was a very young and beautiful girl, and she said, I want to be able to look like the rest of the people. She had this port up here, and it was sticking out, and she said, I can't do that if I have this, needle sticking out. So I listened to her story, and there was some of the docs and interventional radiology that she didn't want to see again. She just felt that they didn't do her justice or whatever. So, we don't side either way. We just listen to her story and try and get them connected up with somebody that will work with them. So I called the interventional radiologist and I said, this is where she's at. She just wants to have a port placed somewhere where, it can be hidden under her clothes, so she can look like a 20-some-year-old, And so he said, he was very receptive. He said, well, we have this new surgeon. He's a pediatric surgeon. And she was very petite and, was probably the size of a, 12-year-old, 13-year-old, teeth. So he said, let me talk to her, and let me talk to that surgeon and see if he can help us out. So it was truly advocating for her, and so then the pediatric surgeon got involved and put a port on her abdomen, and so then she was home. And she didn't come across as non-cooperative, because she was just frustrated with where I said, put yourself in her situation. You have to do TPN every night. So we're really trying to hear the patient's story and really trying to advocate for where they're at with things, and like I said, we're trying to be their negotiators